Hi, I'm Joe Graydon.
I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy, where we bring you the stories behind the health headlines.
This podcast is brought to you by Redix Industries, makers of Utterly Smooth Body Cream. 800-345-7339, on the web at uttercream.com. This year, roughly 300,000 women will be diagnosed with breast cancer, and 180,000 men will get a diagnosis of prostate cancer. This is the People's Pharmacy with Terry and Joe Graydon.
Despite advances in treatment, too many people still die of breast and prostate cancer. How can we make sense of confusing headlines about PSA tests and mammograms?
We turn to two of the country's leading experts for answers. Dr. Susan Love tells you about the latest breast cancer research. Dr. Charles Myers brings us up to date on prostate cancer diagnosis and treatment. What foods are protective?
Coming up on the People's Pharmacy, learn how to reduce your risk from breast or prostate cancer.
First, this news.
In the People's Pharmacy Health Headlines, exercise is just as important for older people as it is for younger adults. A new study had more than 120,000 people in it. They were at least 60 years old, and they were followed for 10 years on average. The researchers also had a separate group of more than 1,000 French people who were 65 years old in 2001. This group was tracked for 12 years. Compared to sedentary participants, those who exercised even a little bit, about 15 minutes of brisk walking daily, decreased their risk of early death by 22%. Moderate and high levels of exercise were even more helpful, lowering the likelihood of dying during the study by 28 and 35% respectively. The researchers conclude that more physical activity offers more health benefits, but that older people can get great results by starting modestly, with 15 minutes of walking every day.
Nutrition experts have long been advising us to eat whole grains, and now epidemiologists have evidence that getting 3 servings of whole grains daily can reduce the chance of an early death. The researchers analyzed data from 12 published studies and from several national health and nutrition examination surveys. All told, nearly 800,000 people from the U.S., the U.K., and Scandinavia were included in the analysis, which covered the time frame from 1971 to 2010. Such studies can't establish cause and effect, but the scientists found a convincing 25% drop in the death rate due to heart attacks and strokes among people who consumed 3 servings a day of whole grains. People following this dietary pattern also had a 15% lower chance of dying from cancer. This recommendation has been made before, and it often causes confusion. Food manufacturers like to slap the words whole grain on their packages to take advantage of the health halo of whole grains, but the products aren't necessarily good sources of whole grains. For that, it's important to read ingredients on the label. You may wish to cook your own bulgur, brown rice, barley, or steel-cut oats. And if you're buying bread, look for a loaf that's dense and has whole grain as its primary ingredient.
The Food and Drug Administration has just strengthened the warning on certain medications prescribed for people with type 2 diabetes. Canagliflozin and dapagliflozin are sold under the brand names Invokana and Farxiga. The FDA is warning that these drugs are linked to acute kidney injury. Patients have been hospitalized with kidney damage. Some landed in intensive care. Others required dialysis, and 4 patients have died. The agency warns that a number of other drugs may interact with these diabetes medicines to increase the risk.
Over the last few years, you have no doubt heard about numerous food recalls because of contamination. The Office of the Inspector General has reviewed the FDA's response in 30 different instances of tainted food. The agency was found to lack policies and procedures that would protect the public health. There were unsatisfactory delays in removing suspected foods from supermarkets. The report said, As a result, consumers remained at risk of illness or death for several weeks after FDA was aware of a potentially hazardous food in the supply chain.
People with insulin resistance have trouble getting blood sugar into cells after meals, but a cup of black tea might help. The scientists in this new study compared the effects of nitrate-rich beet juice and flavonoid-rich black tea in 16 volunteers. All were insulin resistant. They were given 75 grams of glucose in combination with either black tea, beet juice, or water, and their blood flow was studied. Black tea reduced the resistance in all the blood vessels studied, including the tiny ones. Beet juice reduced resistance in only some of the blood vessels. The insulin response was almost 30% lower after the participants drank black tea. Diminished vascular resistance and reduced insulin response are both beneficial reactions. The researchers suggest further studies to determine whether long-term tea consumption could affect blood sugar control. And that's the health news from the People's Pharmacy this week. Welcome to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. Breast cancer in women and prostate cancer in men are among the most common cancers in this country. There are nearly 300,000 diagnoses of breast cancer each year and 40,000 deaths.
Several months ago, Joe discussed some important new research on DCIS, ductal carcinoma in situ, with Dr. Susan Love. For decades, she was an eminent breast cancer surgeon. She's on the board of the National Cancer Institute and is an adjunct professor of surgery at the University of California, Los Angeles. Dr. Love is the Chief Visionary Officer of the Dr. Susan Love Research Foundation. Her book, Dr. Susan Love's Breast Book, is out in its 6th edition.
Welcome to the People's Pharmacy, Dr. Susan Love. It's so nice to have you back.
It's great to be here.
Dr. Love, I have to tell you, this brand new study in JAMA Oncology has created tremendous confusion among not just women, but health professionals as well, about this thing called DCIS. Could you tell us a little bit about, well, first, what is that? And number two, why is this study important and why has it created so much confusion and consternation among your colleagues?
Well, DCIS stands for ductal carcinoma in situ. We've always thought, and our hypothesized, that breast cancer starts in the milk ducts, almost like rust, gets slowly bigger, and then eventually breaks out of the duct, or the duct lets it out, and becomes what we call invasive ductal cancer. So the in situ refers to the fact that it's still in the milk duct. And we thought if we could treat this, we could prevent you from getting cancer. And so we do treat it. And with mammography screening, we can often find microcalcifications, or little specks of calcium that are caused by the DCIS and so are a tip-off. So mammography screening has increased the number of people diagnosed with it, and we were thinking that by actively treating it, we would be decreasing the number of deaths of breast cancer. And what this study showed was looking at 20-year data, women who had been diagnosed with DCIS, regardless of their treatment, whether they had a mastectomy, a lumpectomy and radiation, or just a lumpectomy, had a very low mortality rate from breast cancer, around 5%. And it didn't even matter if the DCIS recurred. They still were about, or recurred as an invasive cancer. It was still about 5%. And actually, the death rate, I think, from other diseases, I forget the exact number, but it was higher. It was more like 8 or 9%. And so what this says is, gee, maybe we weren't right. Maybe this isn't precancer. We were sort of saying it was because it was guilt by association and because it looked bad. But, not everybody who looks like a terrorist is a terrorist, and maybe we were wrong. So this is really making us all re-examine our conclusions about DCIS. And most of the previous data that suggested that it went on to become cancer was based on lumps, not mammographic disease, and it was based on a very small number of people who had been misdiagnosed and therefore not treated and then were followed. Less than 100 total, I believe, or around that range. So this starts to make us think maybe our conclusions weren't so accurate about this.
Well, one of the things that sort of struck me is that whether we call DCIS cancer or precancer or stage 0 or whatever name we use, what was so striking was that regardless of the treatment, the outcomes were no different.
Same.
And, you would think that if we're catching something bad, some abnormal cells early, and we do the most aggressive thing possible, that is for, a mastectomy, what you used to do as a breast cancer surgeon, that we should have better outcomes than if we...
So. And not only that, the people who developed invasion, so say had an invasive recurrence. So when they had DCIS, they had it treated, and they had a recurrence, which looked like invasion, they still didn't have a higher death rate.
Well, I have to tell you that, I'm guessing 15, maybe 20 years ago when we interviewed you on the People's Pharmacy about the concept of early detection, which was something that was just absolutely embedded in everybody's mind when it came to cancer. And you said, there really is no such thing as early detection. There's earlier detection, but by the time you can feel something or even see it on a mammogram, those cells have been growing maybe for years.
Right.
And you got to start thinking about breast cancer, and by the way, maybe some other cancers as well, as a systemic disease. Now, that's not something your surgeon colleagues like to think about. They like to think, oh, I got it. I got it all. The margins were clean.
And that's what the patients like to think, too. I mean, as a patient, you want to think they got it, and not that the cells get out very early on. But the reason that we've shown that, taking in addition to surgery, not for DCIS, but for invasive cancer, having chemotherapy or hormone therapy or targeted therapy, why that makes a difference is because of those cells that are already out. You need something systemic that can get through your whole bloodstream and get to those cells and take care of them. And so that, improvement in survival with adding additional systemic treatments has shown that theory probably was right.
So if a surgeon says to a woman, well, we got it, and your margins are clean, there's no evidence of spread, your lymph nodes are clean, you're fine, you don't need to do anything more. Does that woman need to say, just wait a minute, maybe I need a consult with an oncologist? Maybe the surgeon thinks she got it all, but maybe there are some rogue cells out there someplace that need some follow-up treatment.
No, absolutely. And there are two ways that we got it all is probably not true. One is what you're referring to, that most cancers have knocked cells out into the bloodstream early on. And we now are able to measure circulating tumor cells in the blood. And so we've actually documented that now, just because they get in the blood doesn't necessarily mean they set up shop in another organ. I like to say just because you get on the highway doesn't mean you're going to get to your destination. There are a few blocks along the way. But still, we know those cells are out there. And then secondly, when we look at margins, that's a very crude test. I mean, if you take out a 2-centimeter piece of tissue, to look at every margin would be 3,000 to 4,000 slides. And we do maybe 5. So we're just saying the margins that we sampled look clear. That doesn't tell you that absolutely for sure we got it all.
So what are women and doctors to make of this DCIS study in JAMA Oncology. And, where does this lead? What are the next steps? What does your crystal ball reveal?
Well, I think that what it is going to end up being is that we'll do watchful waiting, as we do in a lot of other cancers, prostate and thyroid, for example. But the problem with watchful waiting for DCIS is we don't have anything to watch. The calcifications that we see on a mammogram are only in one little part of it. And we have no good way to show whether it's getting out, not getting out, or progressing. And so one of the things we're working on, what I'm working on right now at the Dr. Susan Love Research Foundation, is a project to try to map the anatomy of the breast ducts, because that, believe it or not, has never been done.
Whoa, wait a minute. Are you kidding me that we don't know the anatomy?
No, we don't know the anatomy. We're arguing a bit about how many holes there are in the nipple and where the ducts go. The pictures you often see make it look like a pizza, but it's really not, two-dimensional. It's three-dimensional. And we haven't really mapped so that we can, like we have in the lung or the liver, we know where the bronchi are, we know where the bile ducts are. We can say this is the normal pattern, these are the variants. We don't have that in the breast.
And, of course, the problem is that for a woman who is diagnosed next week with DCIS, almost assuredly her surgeon and or oncologist will recommend either lumpectomy, mastectomy, follow-up radiation, and or hormone suppression. 240,000 diagnoses of invasive breast cancer each year, and almost, 95 to 100% get some form of treatment. So
absolutely.
What do we tell them?
Well, I think that right now they're caught. They're caught in a time where we suspect that we're overtreating them, but we don't know how to do less. People are talking now about doing some clinical trials of doing less, and I think that will certainly help, but I still contend that until we have a way to monitor it or to watch it, we're not going to really see a swing away from this overtreatment. We're definitely overtreating it, but we don't know how to do less quite yet.
Dr. Susan Love, thank you so much for talking to us on the People's Pharmacy today.
You're very welcome. It's always a pleasure.
You've been listening to Dr. Susan Love. She's arguably America's best-known breast cancer advocate. Her career has included surgery, teaching, research, and writing. Her best-selling book, Dr. Susan Love's Breast Book, is now in its 6th edition. She's Chief Visionary Officer of the Dr. Susan Love Research Foundation. You can find it online at drsusanloveresearch.org. You'll also find a link from peoplespharmacy.com, and you'll also find a link to the study in JAMA Oncology that Joe and Dr. Love were discussing.
After the break, we'll turn our attention to prostate cancer.
Just as breast cancer affects many women, prostate cancer is one of the most common cancers affecting men. In 2016, it's estimated that 180,000 men will be diagnosed with this condition, and more than 26,000 will die.
Why doesn't prostate cancer get the respect it deserves?
You're listening to The People's Pharmacy with Joe and Terry Graydon.
If you like the information you hear when you listen to The People's Pharmacy, you may also enjoy our book published by National Geographic. It's The People's Pharmacy Quick and Handy Home Remedies, available online at peoplespharmacy.com or at your favorite bookstore. Welcome back to The People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is brought to you in part by Red X Industries, makers of utterly smooth creams and lotions that deeply moisturize to make dry skin feel soft and smooth. The number is 800-345-7339. The website is uttercream.com.
If you would like to order a CD of this show, you can call 800-732-8255. 800-732-2334. Today's show is 1039. That number again, 800-732-2334. Online at peoplespharmacy.com.
Today on the People's Pharmacy, we're talking about two common cancers that affect men and women. You just heard from Dr. Susan Love discussing breast cancer in women. We turn our attention now to men and prostate cancer.
Our guest is Dr. Charles Snuffy Myers. He is a medical oncologist with a research background. He ran clinical pharmacology at the National Cancer Institute for about a decade. He's also a former cancer director at the University of Virginia. Since he had metastatic prostate cancer 16 years ago, he has experience as a patient as well as a doctor.
Welcome to the People's Pharmacy, Dr. Charles Snuffy Myers.
It's great to be here today.
And we are delighted to have you. Dr. Myers, you liken prostate cancer to the canary in the coal mine. What in the world do you mean by that analogy?
Prostate cancer tends to be tied to other diseases, so that it's a signal that other problems exist. If you've been diagnosed with prostate cancer, you're more likely to have a heart attack. If you have a heart attack, you're more likely to have prostate cancer. It tends to be associated with other diseases associated with lifestyle changes like diabetes, colon cancer. So in that sense, it's part of a complex.
Do we know why?
Well, the risk factors include diet rich in red meat, high cholesterol diets are a big problem, lack of fresh fruits and vegetables. The Mediterranean heart-healthy diet appears to reduce the risk of all of those diseases, including prostate cancer.
We'll come back to the issue of red meat and cholesterol in a minute, but you also use golf as a metaphor for prostate cancer treatment. Why golf?
Because if you're a golfer like me, you can't control where the ball goes, and you have to play it where it lands. And when you're diagnosed with a cancer, you could end up with a cancer that is very mild and with prostate cancer not a risk and not need to be treated, and suddenly you might find yourself with a highly aggressive disease and needing to engage in an aggressive and unpleasant treatment. And there's nothing you can do about it as a person except to engage the problem as it's presented to you.
Dr. Myers, speaking of aggressive disease, you yourself have had a personal experience with prostate cancer. I wonder if you'll tell us about it, please.
So in February of 1999, at age 55, I went in for my first prostate cancer screening exam. And I remember they were all just saying, "You have a mass," a moment of silence, "we better biopsy it right now." And over a period of about 10 days, I found that I had a PSA of more than 20, a Gleason 7. It had spread to the seminal vesicles and out of the prostate into the surrounding tissue and to the lymph nodes in the side of my pelvis and the back of my abdomen. And, of course, in that era, those findings would have been associated with a 5% chance of being alive at 10 years. And it's now 16 and a half years later.
Well, as an oncologist yourself, as both a clinician and as a researcher, you understood the risks that you were faced with, perhaps better even than the doctors who were getting ready to treat you. How did you deal with it?
Well, it was a shock because by that point, I'd been specializing in prostate cancer for more than a decade. So I immediately could pull the survival curves up in my brain. And what I decided in my own mind, that if I had done everything that I could do to survive, and it didn't work, I could live with that. But if I left any stone unturned, I would regret it. So I became very aggressive.
Well, what did that entail for you at that point?
Well, of course, this is 1999. Things are different now. I went to Johns Hopkins, and they opened my abdomen up and stripped all the lymph nodes from the kidneys to the top of the pelvis. I had radiation therapy to the pelvic lymph nodes and prostate gland, and 18 months of hormonal therapy.
And yet, even with all of that, you did have a return of the cancer. Is that correct?
The PSA went up to 0.5, and I started leucine, which is an immune stimulant. It's a normal body hormone that stimulates the immune system and is also used to make most of the cancer vaccines. And I did that for 3 years, and that seemed to have finished, put the disease in a dormant state. I don't think I'm cancer-free, but my PSA is undetectable and the years are passing.
You know, one of the things that has puzzled us for quite a long time is why prostate cancer doesn't seem to get the respect it deserves. Breast cancer gets a tremendous amount of media attention. We certainly are all familiar with the pink ribbons, but prostate cancer doesn't. Why not?
I think there are several reasons. One, this is a very heterogeneous disease. It can range from something no more dangerous than dandruff, literally, to a rapidly lethal disease. And the slow-growing, low-risk form of the disease is the most common. And so many oncologists and even family practitioners and patients get confused about whether this is a slow-growing disease that men die with, not of, or whether it's a lethal disease that can kill you because of that range. Second, during most of my career, it's just been a disease in old men, and that didn't attract a lot of the same interest that a breast cancer patient who's 35 might attract. And then there was a lack of really effective treatment, too. So there was a sense of pessimism and hopelessness associated with the diagnosis. You couldn't do anything about it. It was happening in old men that were going to get sick and die of something else, and they might die of the cancer even if you did nothing. And so those are some of the reasons, I think.
Well, that's all changing now, and there are a lot of new treatments, and there's a lot of reason to be optimistic. But the most controversial piece to everything has to do with diagnosis, and in particular, screening.
And using the prostate-specific antigen, the PSA, as a screening tool. Can you clarify this controversy at all?
Yeah, so I'm old enough at 72 to remember treating prostate cancer patients before PSA screening became available. In the 1980s, we would typically see prostate cancer patients at diagnosis where the cancer was everywhere. Their skeleton was loaded with disease. And then screening came in, and all of a sudden I found that the patients being sent to me as a medical oncologist had just a PSA elevated after surgery or radiation. And, of course, the national statistics showed a huge drop in death rate during that time interval. Then the U.S. task force recommended against screening fundamentally, and screening stopped. And in a few short years, I feel like I'm back in the 1980s again. All of a sudden, I'm seeing widespread metastatic disease more commonly than the low-volume recurrence after successful surgery and radiation. So it's clear that the U.S. task force recommendation was a grievous error, and they're right now reevaluating that recommendation. They've asked for input. But when I go to meetings with other oncologists who specialize in prostate cancer and urologists, that we all comment about the same thing. Since screening stopped, we're seeing a tidal wave of far advanced patients who would have been detected early and treated successfully if screening had been left in place.
Now, this does raise the question of when should men start having a PSA test? In their 40s, in their 50s? Do they need to wait till they're 60? Give us some sense of what your recommendations would be about a PSA. And then, is there any hope on the horizon that there will be a better test than the PSA? It's our understanding that it's not very specific.
Well, I guess if you're in a high-risk population, screening should start earlier. So if you have two first-degree relatives, a brother, a father, an uncle with prostate cancer, your risk is above 50%. And screening the first PSA should probably be at 35 years of age, and every other year after that. African Americans have a much more aggressive form of the disease in general, and they probably ought to be screened earlier. There's controversy about when My own personal opinion is it should start in their 40s. But the same thing, if the PSA is increasing steadily, then you know you have a problem. For the general population, 50, 55 is probably a reasonable time to start.
Dr. Myers, when men have a biopsy as a result of a high PSA level, they are then told by their doctor, well, you have a Gleason score. What the heck is a Gleason score? I'm pretty sure it doesn't have anything to do with golf.
No, well, Dr. Gleason did a marvelous thing. Back in the 60s, he was one of the lead pathologists on one of the large randomized controlled trials that was looking at a lot of biopsies and recorded the appearance of cancers and their subsequent behavior and did statistical analysis on a computer and found out which visual features indicated low, intermediate, or high-risk disease. And he had a 5-point scale, 1, 2, 3, 4, and 5. Well, if you look at a sizable cancer mass in the prostate, there are a variety of patterns, and so the first number in the Gleason is the dominant pattern, and the second is the less common pattern. So a 3 plus 3 would be 2 pattern 3. The dominant and secondary pattern are 3. A 3 plus 4 is 3 is the dominant, and there's a smaller area of pattern 4. Over time, it turns out the real difference is between 3 and 4. So a pattern 3 looks like a donut, like donuts lined up on a plate, circles of glandular tissue with holes in the middle, preserving something of the architecture of a normal prostate. And as long as that's present, those cells are not highly aggressive. Pattern 4, that donut-like appearance collapses into a solid mass, and that becomes pattern 4, and that's a signal for a cancer that's aggressive, that can invade and spread. And so although it's a 5-point scale, the most important difference is 3 to 4, and the larger the amount of 4, the worse off you are. So 3 plus 4, 3 dominates and 4 is second. 4 plus 3, 4 dominates, and the 4 plus 3s do worse than the 3 plus 4s. 8s are typically 4 plus 4. And pattern 5 is a highly abnormal, aggressive, lots of mitoses and rapidly growing and very nasty, and that's as bad as it can get. So 2 5s are a 10, and that's highly aggressive disease.
A lot of patients get very confused because they're told you have a Gleason 6, let's say 3 plus 3, and they go, wow, 6, because they're always thinking on a scale of 0 to 10, and 6 sounds scary. But from what you're saying, a Gleason 6, if it's in a number of cores in the biopsy, that might actually be a watch and wait or active surveillance kind of approach. Is that right?
That's right. Most Gleason 6s tend to be slow growing and not at high risk. Occasionally you have a wolf dressed up like a sheep. So occasionally there are 6s that look benign but are really, really aggressive molecularly. And the biggest advance now is there are a series of gene tests you can do on the biopsy specimen to see if your 6 is a wolf in sheep's clothing.
Dr. Myers, I think the question of treatment is one of the questions that's most confusing to men who have just been diagnosed with prostate cancer. There are so many different options. Can you please just describe what they are and what the advantages and disadvantages are?
Well, of course, if you're hunting for an elephant, you don't want a .22, but if you're hunting for a rabbit, you don't need a howitzer. So the aggression of treatment should be proportionate to the threat the cancer poses. And so for Gleason 6, it's not just Gleason 6, but below a centimeter, that's roughly a half an inch in size, hopefully not near the capsule of the gland. That would be typical active surveillance patient.
And what does that mean?
So, well, for those low-grade patients, there's two approaches. Watchful waiting is you and the doctor agree to forget about it and do nothing and pretend you don't have anything. Active surveillance says, well, some of these sixes could be nasty. We better follow you in a systematic way. And so in those patients, you'd get PSAs, say, every quarter, and either imaging or biopsy once a year or every 6 months, depending on the institution you're in. When active surveillance started out, they would re-biopsy the cancer every 6 to 12 months, but each biopsy comes with a serious risk of infection. And so the biggest advance there is the MRI. Prostate MRIs are really remarkable. They can see the cancer in 3 dimensions, and they can even make a guess about whether your Gleason 6 is now becoming a 7, becoming a higher grade, just by the look. And so with the MRI, you don't have to re-biopsy unless the image changes. And so that would be for active surveillance or watchful waiting for the Gleason 6s. There really isn't any convincing randomized controlled trial to show that radiation and surgery have a benefit in terms of survival in those patients. Some people, though, just get very anxious with the idea that cancer is remaining in their body and just want to have it out, even though there's no rational basis. And getting back to the earlier section, this is the group that when people say over-treatment, that's what they're talking about. Then you have sort of an intermediate cancer that is capable of growing and spreading, but only does so to a limited extent. If it leaves the prostate gland, it might go to the lymph nodes in the pelvis and not much beyond that. So it's aggressive but localized. And those patients, many of them, can be put into a disease-free state, or the cancer can be so suppressed that they live out their normal life without the cancer coming back. I steer away from the word cure because we can never know there aren't cancer hidden out someplace but dormant. And radiation therapy to the pelvic lymph nodes and the prostate gland, many of those patients do very well. Or if they have prostatectomy and then radiation to the prostate bed and the pelvic lymph nodes. So this kind of intermediate grade disease. And then you have what we would call high-grade or aggressive cancer that spreads from the prostate gland out throughout the body, typically to bone and lymph nodes, but not limited to just the pelvis. And those patients are the patients that require aggressive systemic treatment.
You're listening to Dr. Charles Snuffy Myers. He's a medical oncologist, founder and director of the American Institute for Diseases of the Prostate.
After the break, we'll learn about new treatments for prostate cancer.
How well do hormone-suppressing drugs work?
What is the cholesterol connection to aggressive prostate cancer?
We'll also find out why breast cancer genes matter for men. You're listening to The People's Pharmacy with Joe and Terry Graydon. If you value the health information you get when you listen to The People's Pharmacy, consider subscribing to our email newsletter. You'll get the latest health news and information on upcoming podcasts delivered to your inbox twice a week. Look for the link at peoplespharmacy.com. Welcome back to The People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon. The People's Pharmacy is brought to you in part by Redix Industries, makers of utterly smooth foot cream with shea butter, helping dry, cracked feet feel utterly soft and smooth. The number's 800-345-7339. The website is uttercream.com.
If you'd like to order a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 1039. That number again, 800-732-2334, or look for it online at peoplespharmacy.com.
We're talking about prostate cancer. This year, 180,000 men will be diagnosed with this condition, and 26,000 will die as a result of metastatic prostate cancer. What can be done to reduce the toll?
Our guest is Dr. Snuffy Myers. He's a medical oncologist with a research background. He ran clinical pharmacology at the National Cancer Institute for about a decade. He's also the former cancer director at the University of Virginia. Since he had metastatic prostate cancer 16 years ago, he has experience as a patient as well as a doctor.
Dr. Myers, people come to you from all over the world, oftentimes because their oncologist has given up on them, or, as you've pointed out, because the disease has become metastatic all over the body. There are some new treatments. Can you go into a little more detail on these hormone-suppressing drugs and what is on the horizon? There's been a recent article in the New England Journal of Medicine suggesting a whole nother approach for people who have genetic variations, a little like the BRCA1 and BRCA2 gene mutations involved in breast cancer.
So standard hormonal therapy for most of my time in the field has been Lupron, or one of the competing drugs, which just puts the testicles to sleep and your testosterone becomes castrate. And that will fail after a period of time. And so there was some tremendous research on how did the cancer manage to grow with the testosterone in the castrate range. And the most common mechanism is testosterone binds to a testosterone receptor in the cancer, and that fused testosterone and its receptor move to the nucleus of the cell and tell the cancer to grow. And so the most common form of resistance is just to make more receptor, like having a big sail in a light wind in order to trap enough testosterone to survive and grow. And that was the most common form. And Xtandi was developed specifically to address that problem. The earlier drugs we had, with drugs like Casodex, Xtandi is roughly 500 times more potent in accomplishing that task. The other interesting mechanism of resistance is testosterone in your testes. Testosterone is made from cholesterol. And lo and behold, this one of the other common mechanisms of prostate cancer resistance is the cancer cell picks up cholesterol and makes its own testosterone. It becomes like a miniature testes and becomes completely independent of the testosterone in your bloodstream. And Zytiga was developed to block the conversion of cholesterol to testosterone. And it's very successful, and that's proof positive, I think, of why cholesterol in the diet probably makes a difference, because the cancer can make its own testosterone from cholesterol with a fairly simple change. There are other things that we can target, and the article you mentioned was in the October 28th issue of the New England Journal of Medicine. And by way of background, one of the things that makes aggressive cancer hard to treat is the cancer can change over time. It can evolve. And to do that, it has to be able to vary its genetic makeup. So many of the most aggressive cancers actually have a defect that prevents them from successfully repairing DNA. This next step in this story is the breast cancer genes, BRCA1 and 2. And those are DNA repair genes, and when they're gone, those families, 80% of the women get breast cancer. For BRCA2, 40% get cancer of the ovary. What many people don't realize is those families have a very high risk of prostate cancer. Up to 40% get prostate cancer.
So, Dr. Myers, why are BRCA1 and BRCA2 relevant for men?
Well, 40% of the men in those families get prostate cancer.
So the women get breast cancer, the men get prostate cancer.
Yeah. And the prostate cancer they get tends to be much more aggressive. So when breast cancer, ovarian cancer, or prostate cancer have lost BRCA1 or 2, they have to have a fallback to repair their DNA, and a protein called PARP is the fallback. And so drugs have been developed to target PARP. And that's been a huge breakthrough for cancer of the ovary that's BRCA2 positive. Lynparza is widely used for that drug. The generic name is olaparib. Well, it turns out that BRCA1 and 2 aren't the only DNA repair genes cancers can lose. There's a rather long and growing list of other DNA repair genes that get lost. And with each of these losses, PARP becomes the fallback. And so the Lynparza and drugs of that class work against these other DNA repair mutants. So in the paper in the New England Journal of Medicine, they had 49 men who had failed Taxotere chemotherapy, after which there aren't very effective agents. And out of the 49 patients, 33% responded to Lynparza, which for an oral drug with modest side effects was already a breakthrough. But it turns out that 16 of those men had a DNA repair defect, and 14 of those responded, giving an 88% response rate, which is just stunning. Here you have a drug that's well tolerated, and men have failed chemotherapy. All of a sudden, here's a drug that gives an 88% response rate if your gene test on the cancer reveals one of these DNA repair defects. So it's very exciting. And this form of therapy doesn't need hormonal therapy to work.
Dr. Myers, you just mentioned what has to seem, from your perspective, like a breakthrough. What was the name of that medication again?
Lynparza, Lynparza.
And that's for men who have a specific genetic defect, which I assume is detectable.
Yes.
Now, you have also been exploring other treatments for prostate cancer. Can you tell us a little bit about why you often prescribe metformin, and what about a controversial drug called Avodart?
So metformin's story is actually fascinating. It was released for diabetes in 1958, and the story actually goes back to the 13th century France when they discovered that extract of French lilac would treat the symptoms we now recognize as diabetes. And after World War II, the active ingredient was purified and made an oral diabetic drug, but had serious side effects. And so they took the natural compound and changed the molecule in a few ways, and that's metformin. I guess maybe 7 years or so ago, some of the diabetic drugs were shown to cause Avandia, for example, is shown to cause heart attacks and strokes in diabetics, even though it helped blood sugar control. And so all diabetic drugs were looked at, and lo and behold, men and women on metformin had a 50% reduction in the overall cancer death rate. Also a decrease in death rate from heart attack and stroke, without any clear explanation that the drug doesn't alter cholesterol or blood pressure. And I remember when that came out, I couldn't believe a drug this old and commonly used could do that, and we didn't know about it. But it turns out to be true. It has activity against multiple cancers and does reduce the risk of heart attack and stroke and some forms of dementia. So for prostate cancer, it's a very interesting drug, and there are multiple reasons to use it. If you start hormonal therapy and give a man a castrate testosterone, insulin doesn't work very well. And so they tend to get obese, and their blood sugars tend to rise, blood pressure goes up. They develop what we call metabolic syndrome, pre-diabetes, and diabetes. And so there's a randomized trial with Lupron alone versus Lupron plus metformin, and metformin dramatically reduces all of those side effects of hormonal therapy. So starting metformin when you start hormonal therapy is a safety issue.
Now, Dr. Myers, when you talk about hormonal therapy, you're actually talking about testosterone blocking medication, aren't you?
Yes, removing testosterone. Give a man a castrate testosterone.
And that's because testosterone acts like fuel to the fire, as it were.
Like the volume knob on an amplifier.
So the metformin, a drug, as you pointed out, that's been around for decades and is relatively well tolerated, can work not just for reducing the risk of breast cancer and several other cancers, but it's also beneficial against prostate cancer?
Yes. And so I guess the other part of the story is its anti-cancer activity against prostate cancer. And there are several very interesting papers, one from Memorial Sloan Kettering, that if you're on metformin when you have radiation therapy, the radiation therapy is much more likely to be curative. There's a very well-done study from Switzerland where they took men who had failed hormonal therapy and chemotherapy was all that was left, and roughly a quarter of the patients, the cancer was controlled by metformin.
Dr. Myers, one of the ways that men can find out about the variety of treatments that are available is through a support group. Can you tell us, please, from your perspective, what are there advantages for a man to participate in a support group? And if there are, how could a man find a prostate cancer support group in his area?
Wonderful question. Many men are reluctant to go to support groups because they view that as holding hands and singing Kumbaya, and that's not a man thing of the generation of us that are getting prostate cancer. But it's really much different. It's the best place for you to find out information about how to treat your disease, what doctors in your area are patient-friendly and skilled and which ones aren't. And then after you find out, you go for the information, then you get the camaraderie. And many of my patients who've been through treatment get tremendous positive emotional feedback by going to the meetings and helping newly diagnosed patients, sort of feed it forward emotional reward. And so they're wonderful. The best place to find out about support groups is to use Google search or one of the other search engines. And in the United States, the US2 International is the dominant support group organization based in Chicago, but with chapters throughout the United States. So go up to Google and search for US2, and you'll find the links that you need. And most communities have them or they're nearby. It's a wonderful organization.
Now, is that 2 a numeral or a TOO or a TWO?
TOO.
Okay.
Okay. Dr. Myers, for the listeners who are concerned about prostate cancer but have not been diagnosed yet, they're probably thinking, well, what can I do? What's the best diet? What kind of exercise program? Should I be eating meat? Should I be a vegetarian? What about fish? What kinds of vegetables are best? Can you give us sort of a quick overview? You have certainly written the book on this, the new prostate cancer nutrition book. On the cover, we see onions, we see avocados, we see kiwi, we see tomatoes.
Pomegranates.
Pomegranates, one of our favorites. Help us understand the do's and don'ts of dieting.
Well, it gets to be fairly simple because prostate cancer is the canary in the coal mine, and it's part of a whole pattern of illness that is diet and lifestyle based. And so the best diet is either a Mediterranean heart-healthy diet or an Asian diet typical, for example, of Okinawa. My wife is Sicilian origin, and so we focused on the Mediterranean heart-healthy diet. And this diet has been subjected to multiple randomized controlled trials. It's been shown to reduce the risk of many cancers and to reduce the risk of diabetes, heart attack, stroke, even prolong the life of Alzheimer's patients or delay the onset of Alzheimer's, a variety of illnesses. So it gets to be fairly simple. The Mediterranean diet is full of fresh fruits and vegetables. It is not a low-fat diet. About 40% of the calories come from olive oil and nuts and things like that. And one of the more interesting trials was the Predimed study, again in the New England Journal of Medicine, which compared a low-fat diet to a Mediterranean diet with a quart of olive oil a week or a similar volume of nuts. And the trial had to be stopped at 4.5 years because so many people died on the low-fat diet. So the answer in terms of general health is very straightforward. And I like the simplicity because it covers all bases.
Dr. Myers, are all nuts created equal? Should men be eating certain nuts and avoiding others?
Well, this is a controversial area. In prostate cancer, the omega-3 fatty acid found in flaxseed, alpha-linolenic acid, has been associated with disease aggression. And pecans and walnuts are also high in alpha-linolenic acid. And So I recommend my patients stick to nuts that are rich in monounsaturated fats, similar to olive oil. So almonds, pistachios, cashews, macadamia nuts, hazelnuts would fit that role.
Dr. Myers, is there a take-home message you have for our listeners, the men who might be susceptible to prostate cancer and the women who love them?
Well, yes, this is a disease that can be managed very successfully. And the first step is to find out where you are on this disease spectrum and then to choose the appropriate treatment. If you have a low-grade disease, don't use a howitzer to hunt for a rabbit. But if you have aggressive disease, find someone who's going to give you the best modern treatment, because the differences can be night and day and your survival can be dramatically prolonged.
Dr. Charles Myers, thank you so much for talking with us on the People's Pharmacy today.
It was a pleasure.
You've been listening to Dr. Charles Snuffy Myers. He's a medical oncologist with a research background. He ran clinical pharmacology at the National Cancer Institute for about a decade. He's also a former cancer director at the University of Virginia. Since he had metastatic prostate cancer 16 years ago, he has experience as a patient as well as a doctor.
Lynn Siegel produced today's show. Al Wodarski is the engineer. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
The People's Pharmacy is made possible by Redix Industries, makers of Utterly Smooth Extra Care 20 Cream, with 20% urea for extra skin protection. The number's 800-345-7339. The website is uttercream.com.
If you would like to order a CD of today's show or any other People's Pharmacy broadcast, the number to call is 800-732-2334. Today's show is number 1039. That number again, 800-732-2334, or you can find it at our website, peoplespharmacy.com.
And when you visit our site, you can check out information on prescription drugs, herbal medicines, and home remedies. You can share your own experience and your thoughts on today's show.
When you go to the website, you could sign up for our free online newsletter or the free podcast of the show. You will also find links to the research articles that we discussed during the show. You can listen to the podcast at your own convenience, or you can share it with a friend. It's all there at peoplespharmacy.com.
In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thanks very much for listening, and please do join us again next week.
We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to The People's Pharmacy.